every woman's journey is unique. And in every step, Bayer is there for her. For over 60 years, Bayer has been leading innovations in women's health across the Philippines and the world. This legacy has positioned Bayer as a world leader in female hormonal contraception. In 1960, after an extensive research journey on female hormones, Bayer introduced the first combined oral contraceptive pill. This innovation led to immense social change and opened a new world of opportunities for millions of women. Through decades of leadership and research, we developed other innovative products to help address various women's health concerns in a woman's continuing journey. Diane 35 has been part of the Bayer portfolio for 30 years and continues to give every girl a boost of confidence. Diane 35 helps treat hormonal acne and hirsutism. Yaz is the world's first ever combined oral contraceptive with shortened hormone-free interval. The drospirenone in Yaz has anti-androgenic properties, which effectively treats moderate acne in women who elect to use oral contraception. The drospirenone in Yaz has anti-mineralocorticoid properties, which reduce estrogen-related fluid retention. Yaz comes in a 24-4 regimen that provides stable and effective suppression of ovulation. Yaz is also indicated for premenstrual dysphoric disorder, or PMDD, and dysmenorrhea. Similar to Yaz, Yasmin also contains drospirenone with anti-mineralocorticoid and anti-androgenic effects, which are beneficial for women who experience hormone-related fluid retention and for women with acne and seborrhea. Women with endometriosis do not have to live with pain. Visan is a targeted treatment for endometriosis, offering sustainable and safe long-term treatment with proven pain relief. Women can continue to live a productive life. Choosing birth control is one thing, but managing heavy periods is another. That's why we developed Mirena, an intrauterine system that does both. Bayer remains committed to improving the lives of women even further by providing an avenue where medical professionals can empower their patients and women's voices can be heard. And as part of our shared advocacy of improving women's health, we collaborate with OB-GYNs, dermatologists, and pharmacists through lectures and webinars that discuss the latest data, research, and advancements in the medical field. To make information on women's health accessible to all, we launched Ask Mara, a Facebook page and chatbot where women can easily access information on women's health topics such as contraception, endometriosis, and hormonal acne. As the country's leader in women's health, Bayer continues to help Filipinas make informed decisions through reliable treatment options and initiatives. Whether you're a young girl with hormonal acne or a grown woman with a flourishing career, you can always count on Bayer. 60 years ago, our pill changed the world. But together, we can create a future where women can have a choice. A choice to live the life they want. A choice of their own.
I would like you to join me on a virtual tour of the CP Manahan Pavilion, which is the delivery room of the Makati Medical Center. Here we find ourselves in the 5th floor. Directly ahead of us is the ultrasound section. Down the corridor to the left is the entrance to the delivery room. The CP Manahan Pavilion is named after Dr. Constantino Manahan, who is considered the father of modern Philippine obstetrics and gynecology. Upon entering, we find ourselves in the triage area where patients are greeted and vital signs are taken. Here is our friendly reception area staff. Once the patient is initially seen, they are led through the residence triage area where the central monitoring is done. The patient then enters the examination room where fetal monitoring, if needed, is done as well as physical examination. From the examination room, if the patient is for admission, they are brought to the high-risk observation room if needed, or the various labor rooms. Each of the private labor rooms has a companion's chair plus television. The delivery room is well lit and spacious with high ceilings. The first room to the right is the interview room. There are comfortable sofas and we see memorabilia belonging to Dr. Constantino Manahan, who was one of the co-founders and was the first medical director of the Makati Medical Center. Going further down the corridor, the first room on the left is birthing room 1. The room rivals a hotel room and is a very comfortable space where a patient can go into labor and deliver. This also serves as a recovery room after delivery. The room has its own toilet and shower. There is also a very nice view of Makati from the large windows. Going farther down the corridor, the next room is birthing room 2. This is the antechamber where companions such as a doula or photographer can rest to give the couple privacy. When we enter, we see the water delivery tub. We do our water immersion deliveries here. This room serves as a birthing room but was constructed specifically to cater to water births. This is the best water birth facility in the country. Water immersion delivery patients are given priority to this room. The tub is large enough to maintain the correct water temperature for water birth. This enables the couple to have their own water birth delivery in clean, comfortable surroundings and at the same time gives them the highest level of safety since it is inside the delivery room. The monitoring can be viewed remotely at the central monitoring area. There are 5 operating delivery rooms. The delivery rooms are large, ultra-modern, well-lit, completely equipped, and staffed by well-motivated and excellent personnel. Should a COVID or infectious disease case be present, we have the negative pressure operating room. Patients after delivery are sent to the recovery room to be cared for and monitored. The ultrasound section has the most modern and clear ultrasound machines. There is a large screen where the patient can watch the ongoing ultrasound. Once the ultrasound is done, the printed report is ready in 10 to 15 minutes. But a really distinctive characteristic of Dr. CP was his kindness and compassionate care for his patients and people in general. Dr. Constantino P. Manahan can arguably be considered the greatest of all time in the field of obstetrics and gynecology in the Philippines. His brand of medicine lives on through the physicians and staff of the Makati Medical Center, who to this day continue to provide excellent, kind, and compassionate care to their patients.
every woman's journey is unique. And in every step, Bayer is there for her. For over 60 years, Bayer has been leading innovations in women's health across the Philippines and the world. This legacy has positioned Bayer as a world leader in female hormonal contraception. In 1960, after an extensive research journey on female hormones, Bayer introduced the first combined oral contraceptive pill. This innovation led to immense social change and opened a new world of opportunities for millions of women. Through decades of leadership and research, we developed other innovative products to help address various women's health concerns in a woman's continuing journey. Diane 35 has been part of the Bayer portfolio for 30 years and continues to give every girl a boost of confidence. Diane 35 helps treat hormonal acne and hirsutism. Yaz is the world's first ever combined oral contraceptive with shortened hormone-free interval. The drospirenone in Yaz has anti-androgenic properties, which effectively treats moderate acne in women who elect to use oral contraception. The drospirenone in Yaz has anti-mineralocorticoid properties, which reduce estrogen-related fluid retention. Yaz comes in a 24-4 regimen that provides stable and effective suppression of ovulation. Yaz is also indicated for premenstrual dysphoric disorder, or PMDD, and dysmenorrhea. Similar to Yaz, Yasmin also contains drospirenone with anti-mineralocorticoid and anti-androgenic effects, which are beneficial for women who experience hormone-related fluid retention and for women with acne and seborrhea. Women with endometriosis do not have to live with pain. Visan is a targeted treatment for endometriosis, offering sustainable and safe long-term treatment with proven pain relief. Women can continue to live a productive life. Choosing birth control is one thing, but managing heavy periods is another. That's why we developed Mirena, an intrauterine system that does both. Bayer remains committed to improving the lives of women even further by providing an avenue where medical professionals can empower their patients and women's voices can be heard. And as part of our shared advocacy of improving women's health, we collaborate with OB-GYNs, dermatologists, and pharmacists through lectures and webinars that discuss the latest data, research, and advancements in the medical field. To make information on women's health accessible to all, we launched Ask Mara, a Facebook page and chatbot where women can easily access information on women's health topics such as contraception, endometriosis, and hormonal acne. As the country's leader in women's health, Bayer continues to help Filipinas make informed decisions through reliable treatment options and initiatives. Whether you're a young girl with hormonal acne or a grown woman with a flourishing career, you can always count on Bayer. 60 years ago, our pill changed the world. But together, we can create a future where women can have a choice. A choice to live the life they want. A choice of their own.
Okay, good afternoon, everyone. So we still have 1 minute left, but I think we can start already. So I'm Dr. Maria Cristina Miravales, the Layfora coordinator. and the OPD head for the Department of OBGYN. So as we all know, March is the International Women's Month, but we also celebrate Endometriosis Awareness Month, no? So to start the lay forum, we will have an invocation first. So may we call on Dr. Rona Lapitan to lead the prayer. Dr. Rona.
Dear God, thank you for the women hearing this prayer. Thank you for her heart. May you bless her and fill her with your incredible peace. Wrap her in your love. May she feel confident and worthy. Help her with anything she is struggling with. Surround her with encouragement and give her your precious wisdom. May she experience joy today. Amen.
Amen. Thank you very much, Dr. Rona Lapitan. And for our welcome remarks, may we call on our indefatigable chairman, Dr. Mercedes Viduya. She's the present chairman of the Department of Obstetrics and Gynecology. Dr. Viduya.
Good afternoon to all the doctors and patients who are here with us today in this lay forum. As we all know, and dysmenorrhea is a pressing problem that affects our work and our daily living. Sorry. Today, we are privileged to have two of the best infertility experts from Makati Medical Center, Dr. Limson and Dr. Emma Caringal, who will share their expertise with us about pelvic endometriosis. So let us all relax, stay put, and listen as we learn together with the lectures that they are about to give us. Thank you.
Thank you very much, Dr. Viduya. And now let's go to the lecture proper. Can I have this next slide? For our moderator, let me introduce her to you. She's the founding member of the Philippine Society of Fertility Preservation. She became a medical director at San Antonio Medical Center in Lipa City, Batangas, department chairman of Obstetrics and Gynecology at Mary Pediatrics Medical Center, Lipa City, Batangas, and a visiting consultant here at Makati Medical Center. May we call on Dr. Emma Reyes Caringal. Dr. Caringal, the virtual floor is yours.
Thank you very much, Dr. Tina, for having me and as a moderator for our lay forum today. Good afternoon, everyone, doctors and our mothers and single mothers and teenager guests. So, there. So to introduce our lone speaker for this afternoon, she is a clinical associate professor of the UP College of Medicine, PGH. She is the section chief in the section of reproductive endocrinology and infertility of the Makati Medical Center. She is also the secretary of the Philippine Society for Reproductive Medicine. May I introduce our speaker for this afternoon, Dr. Margaret Joyce Cristi Limson, MD. Dr. Emma, the floor is yours.
Thanks, Ma'am Emma. So good afternoon, everyone. So I will be giving a short lecture about endometriosis. Okay. All right. So this month is Endometriosis Awareness Month. Okay, so it is very important and something that is very close to our hearts, and it is our advocacy to educate and to be able to help the women who suffer from this disease. So good afternoon. Welcome to our lay forum. This is brought to you by the Department of OBGYN of the Makati Medical Center. And of course, we would like to thank our sponsor, Bayer. I will be talking about endometriosis. And again, no, it is something that we would like to increase awareness about. March is Endometriosis Awareness Month, and we will be talking about this disease in detail. So the title of our lay forum is Endometriosis, Don't Suffer in Silence, and let's talk about it, period. And that's exactly what we're going to do today. We will have a short lecture where we will share our knowledge about endometriosis. And after that, it will be a free-flowing discussion. And you can type in your questions in the chat box, and we can discuss whatever it is that you have in your mind. Okay. So endometriosis, the problems that it causes pain. So there's dysmenorrhea, fatigue, infertility, and painful intercourse. So let's start with a quick poll. So I would like to ask the attendees to please maybe raise your hand or type in the chat box your if it applies to you. So me, oh, that's me, ganyan, no? So it's really about questions about endometriosis. Okay, so the first question. Do you often experience pelvic or abdominal or lower back pain before or during your periods that limits your activities and or might require the use of pain medications? So yes or no? Okay, so type in the chat box. Ako yan, nung bata ako. Yes, that's me. Then hindi na ako makapag-aral if I have my period and then the pain is there as well. Okay. Second question. Do you often experience pelvic or abdominal or lower back pain in between your periods? So not predictable. That will also limit your activities and or requires medication. Ako din yan. Okay? When I was younger. So is that, okay, I see some of our attendees. Yes. Oh, there are others. No. Okay. Sige. Siguro yung mga lalaki dyan sa audience, no. Pero if you have your sisters, yung mga inyong mga girlfriend, yes. Third question, okay, pwedeng secret na lang. So just say yes on your own. Do you often experience pain during sexual intercourse? Okay. So this is also a symptom of endometriosis. Okay. And 4, do you sometimes avoid sexual intercourse because you don't want to experience the pain? Okay, you want to avoid the pain. So yes or no? Okay. If you answered yes to one or more of these questions, then you could have a condition that is called endometriosis. Okay. So we will now discuss frequently asked questions about endometriosis. So endometriosis occurs or affects about 1 in 10 women of the reproductive age group. Okay. So it is about 1/3 of women with infertility have endometriosis, and 2/3 of women who have chronic pelvic pain actually have endometriosis. Now we have here the female reproductive system. So the OBs here in the group, of course, you don't need to know about this, but those who do not or not aware, so in this part is the endometrial cavity, and it is lined by the endometrium. So that part, the endometrium, is the one that thickens in response to the menstrual cycle, the hormones in the menstrual cycle. So it thickens and it will be shed and it will be thin out, okay? Now, that lining, when it is outside the uterus, when it goes outside of that endometrial cavity, is what endometriosis is all about. So there are endometrial-like tissue from the endometrial cavity that will be develop or will be implanted outside of the uterine cavity. So it can be in the surface of the uterus. And one of the most common sites will be the ovary. And also in some very distal portions like the lungs, no? Pwede rin pong umabot ang endometriosis doon. Okay? So what happens? So the endometrial tissue, which is supposed to be just contained within the endometrial cavity, that is outside of the endometrial cavity, will behave like the endometrium. So they will respond to the hormones that is produced by the body. And these lesions, okay, will bleed when the patient has her menses. And in some women, the endometrial tissue or the implant is on top of the ovarian tissue or the ovary, it will cause invagination and it will also bleed, and there will be collection of blood in that, and it will form a chocolate cyst. So it's like old blood. So that is the endometriotic cyst. It also causes some sort of inflammation, and there will be some scarring and fibrous tissue, okay, between the pelvic tissues, resulting to abnormal pelvic anatomy. So these lesions, okay, which are not supposed to be in those areas, respond to the hormone estrogen. So estrogen is known as the female hormone. So what causes endometriosis? Why does it happen? So the most popular etiology, okay, known etiology for the pathophysiology of endometriosis is the retrograde menstruation theory. It is when the menses that's supposed to be within the endometrial cavity will go back, flows back, or in a retrograde manner through the fallopian tubes and into the pelvic cavity of the woman. Now, most if not all women will have some degree of retrograde menstruation, but because of immune issues, now when the body does not recognize these tissues as abnormal and allow them to persist, or for some genetic reason, these endometriotic tissue will persist outside of the endometrial cavity. Now, some other theorized pathophysiology are when, you know, a woman undergoes surgery, let us say nanganak siya, na CS, okay, or vaginal delivery, and there will be some endometrial tissue which will be sloughed off, and then we will find some endometriotic implant in the perineal area or in the anterior abdominal wall where the incision was made. Sometimes, no, how do we explain endometriotic tissue or implants very far from the uterine cavity, such as in the lung? Now, the implants may be coarse to the blood vessels or the tissue fluid or the lymphatics. Now, what are the factors that increase the risk for having endometriosis? So if you look at this list, okay, infertility increases the risk of endometriosis. So we mentioned that 1/3 of women who have infertility actually have endometriosis. So excessive exposure to menses. So if the woman has early start of menstruation or late menopause, if there's short interval between menstrual periods, there's heavy flow of menses more than 7 days. Also, women who are a bit on the heavier side, who have high levels of estrogen in the body, and the other extreme, now those with low BMI, are also predisposed to having endometriosis. Again, women who have history of endometriosis in the family, like the mother, the aunt, or the sister, because, you know, this may run in the family. Those with obstructive reproductive tract anomalies also be predisposed to having endometriosis. Now, what symptoms should one look out for? Okay, what are the signals? Okay, so we have the classical symptoms of endometriosis. So these were the ones that we shared earlier during the poll. Dysmenorrhea or painful menstruation. Okay, so this is a classic symptom of endometriosis. And of course, some women might not only suffer from pain when they have their menses or right before their menses, they may also have pain in between periods or a cyclical pelvic pain. Those who have pain during intercourse, diba hindi naman dapat talaga masakit intercourse. So when they have pain or there's something like when the man's organ will hit something inside, para may tinatamaan ko dun sa loob. So that is also a classical symptom of endometriosis. Okay, so women will complain of infertility and this symptom, fatigue. Some women with endometriosis manifest with fatigue. Now, other symptoms which are cyclical, okay? So there is cyclical bloating, this diarrhea or constipation, dyschezia or painful defecation. So if these patients have bowel symptoms related to when they have their menses, we sometimes have a suspicion for deep infiltrating endometriosis. Okay, some will have neurological symptoms like dysuria, or when it is painful when they have their menses, or when there is presence of blood in the urine, or that is what's called hematuria. Some will also complain of rectal bleeding. Okay, shoulder pain when they have their menses, and there are other symptoms that patients may complain of. Now let's go talk about pelvic endometriosis and infertility. As was mentioned earlier, about 33% or 30 to 50%, okay, now it's 30 to 50%, those with endometriosis may actually suffer from infertility. And why does this happen? Okay, there's a lot of inflammation going around, and there is a formation of scars and adhesions which may distort the uterine anatomy. There will also be immune issues, such as when the immune system will attack the embryo that is formed. There is the egg and sperm oocyte interaction is also affected, and endometriosis may also negatively alter the endometrium during implantation. So what should we do, or what should the woman do if she is experiencing one or more of these symptoms? It is known and it is established that diagnosing this disease early and understanding some understanding of endometriosis may actually result in better management of a woman's symptoms. So a lot of patients who are very debilitated by this disease found that when they actually learn or understand and talk to the doctors and understand the underlying problem, then they seem to have better control of the disease and, to a certain extent, better quality of life. Okay, so there's this understanding. No, knowledge gives them power, and it may help them feel that empowered if they understand the disease more. So do you also know that there was a study that showed that the average time for a young lady, for an adolescent to be diagnosed with endometriosis was around 5 to 8 years. So there was this normalization of the pelvic pain that a woman will experience. And so the parents or the aunts or the lola will just say, no, that's really normal. Kapag magregla, masakit talaga. Not really addressing the symptom of pain of these young women. So that normalization leads to delayed diagnosis of endometriosis in these women. So we advise you to consult your OBGYN. And what should you expect during the gynecologic consultation? Of course, your doctor will ask you questions regarding symptoms, symptoms related to menses, and the medical and family history. And be ready for a pelvic examination. So your doctor will probably consider doing a speculum examination in most patients. And we will ask for your permission to do a pelvic examination. So we will insert 2 fingers in the vagina and try to palpate. No? Meron ba kaming nakakapang nodularities or areas that are tender? And also try to check if there are palpable cysts in the pelvic area. We will also consider doing a rectal exam as well, because sometimes the lesions are more palpable through the rectum. Now, how is pelvic endometriosis confirmed? So you may have a clinical suspicion that a lady or a woman has endometriosis. Classically, laparoscopy was considered the gold standard in diagnosing endometriosis. So there's a camera. So this is a type of surgery. And then we will look for lesions that are classically endometriosis. So endometrial blebs, we see powder burn lesions, white lesions, scarring or puckering in some areas of the pelvis. And of course, sometimes we do see endometriotic cysts. But not all women will have to undergo laparoscopy just for us to say that the patient probably has endometriosis. Okay, your doctor will probably request for an ultrasound to confirm the presence of an ovarian cyst or an ovarian endometrioma, yung tinatawag natin na chocolate cyst, or even the presence of deep infiltrating endometriosis. Now, what are the complications of endometriosis, aside from a very horrible or poor quality of life? 4 in 10 women with infertility have endometriosis. Again, there is inflammation from endometriosis, which may damage the sperm or the egg, or interfere with the egg and sperm interaction. And the fallopian tubes may be blocked by scarred tissue, so there will be distorted anatomy. Now, the key question, is there anything we can do? Is there treatment for endometriosis. Unfortunately, there is no real cure for endometriosis, but we can actually help reduce the symptoms, the selection of the right treatment. Endometriosis is known to be a chronic, recurrent, and lifelong disease. But, do not be dismayed because there are ways wherein we can treat endometriosis long term. Now, what are the indications for treatment? The same pain, the presence of an endometrioma, and we also offer treatment for those who are wanting to get pregnant. Now, what are the factors that the OBGYN will consider when deciding what form of treatment to offer you? First of all, of course, will be the patient's preferences or your preferences, the type of endometriosis that is present, and how bad are the symptoms of this patient. Of course, whether or not a patient is wanting to get pregnant or desirous of pregnancy plays an important role, because usually we have these patients who come in who are trying to get pregnant, so with some fertility issues. But of course, there is also pain. So it is difficult to actually treat pain and infertility at the same time. So sometimes we have to prioritize which symptom is more pressing for the patient or the couple. Of course, costs, advantages and disadvantages, and side effects of the treatment will also be taken into will be of primary concern. The history of previous treatment, and of course, the expertise of your doctor will matter. The medical management is now considered the first treatment that we will consider for our patients with endometriosis. So it consists of, we consider giving pain relievers and hormones, okay? We give progestins, okay? We also give the, combined oral contraceptive pills. So these are the ones that we use for contraception, the same ones. And there's also the drug that's called GnRH agonist. And of course, there are other second-line medications, GnRH antagonists. And we even consider giving aromatase inhibitors. But the others are second-line medications for endometriosis, or also danazole. Now, how does hormone treatment resolve the pain? Remember, the key hormone there is, estrogen. So we want to give something that has progesterone to counteract the actions of estrogen. So hormonal treatment will stop the activity of the disease and the pain symptoms. However, when we discontinue the medication or the hormonal treatment, the symptoms will come back, okay? So it is not known, or we cannot tell which patients the symptoms will go back, or those that will have persistent improvement of pain after discontinuation of treatment. Okay, progestin-only pills are considered first-line treatment for endometriosis. It not only inhibits ovulation and lowers estrogen, and this is the mechanism in which it actually inhibits the growth of these implants that are outside the endometrial cavity. It also inhibits the formation of blood vessels that feeds these implants and makes them grow and allows them to become inflamed. It also modifies immune response and decreases inflammation. Now, there are different types of progestins. That's why we have different options in the management of endometriosis. So different effects and properties. So these, the decision will be left to your doctor, and she will discuss with you the benefits of each and whatever mode of how the progestin can be given to you and what is acceptable to you. Now, classically, GnRH agonists are one of the strongest or most effective medication for the use of for endometriosis. But the side effects of GnRH can be extreme, okay, because it completely withdraws estrogen in the body, producing a pseudo-menopausal state. So some patients will complain of severe hot flashes, init na init, and we can't give it long-term because it has negative effects on the bone. Patients, if it's given long-term, can suffer from osteoporosis or weak bones. Okay, so menopausal symptoms are common, and there will also be some degree of vaginal dryness, insomnia, para talagang menopause sa menopause. So progestins may have also have their own side effects, so some bloatedness, of course, there is also some weight gain there. Okay. So GnRH agonist has been known to be very effective, progestins as well. So if you're choosing, if a patient's symptoms can be controlled by something that does not have as many side effects, of course, you will go with something that has good benefit, but less, much less side effects. Now, medical management for pain infertility. Once pain is controlled, women with endometriosis will have the desire for pregnancy. Medyo nakalimutan na nila, no? Severe pain during their menses. So I have patients when they see me, doc, let's just control the pain first because I really, poor quality of life. I cannot work, I cannot function very well. And then 3 or 6 months later down the line, they say, doc, I think I'm ready to try. So we have to stop the hormones because they are usually contraceptive. And eventually we start trying. We do not keep the patients on hormone-free windows nang walang ginagawang aggressive treatment for infertility. Kasi sayang, no? Because the symptoms will come back. Okay, even for some immediate, when they discontinue, in a month to 3 months, the symptoms start coming back. Okay, it was been found that ovulation after the discontinuation of hormones will resume rapidly. Okay, and there are some studies that show some progestin-only pills do not cause reproductive toxicity nor abnormalities in pregnancy. Now, what are the side effects of hormonal treatment? Okay, some patients can complain of headaches, acne. Okay, I mentioned earlier, some weight gain. Okay, abnormal uterine bleeding is a very common side effect, and it's a common side effect that may make the woman consider to discontinue the medication. Some patients complain of fatigue and again, hot flushes. Now, is surgery an option for patients with endometriosis? Okay, surgery can actually provide pain relief and enhance fertility in a select group of patients. So these patients who are young, okay, those with good ovarian reserve, okay, may actually benefit from surgery. Now, surgery for endometriosis may include the removal of a cyst, okay, or burning of endometriotic lesions, and maybe lysing or removing adhesions. And the goal is to restore the pelvic anatomy. Now, ideally, the surgery that will be done for a patient with endometriosis should be the first and should be done very well and should ideally be the last, okay? Because remember, endometriosis can recur. And recurrence rate can be as much as 30 to 50% in 5 years, okay? Again, remember that endometriosis is a chronic, recurrent, progressive disease. Now, I would probably consider doing surgery outright in patients, okay? So I will not even offer medical treatment to these patients. If I think the patient might have, cancer, or if the ovarian cyst may actually be cancer, or if I am unsure, okay? If a patient is a bit older or in the postmenopausal group, I would not be as conservative. I would probably consider surgery sooner. And also for those who have obstructive lesions, okay? So those who present with bowel or ureteral obstruction, I would probably be pushed to doing surgery for these patients. Again, the goal of surgery in patients with endometriosis and infertility is to restore reproductive anatomy, but still being able to preserve the function of pelvic organs, okay? Ideally, it should be approached laparoscopically, and for patients with minimal or mild stage endometriosis, surgery may actually reduce pain and increase spontaneous pregnancy rate. But you have to take note, okay, whether done laparoscopically, robotically, or by open surgery, removal of that ovarian endometrioma or doing a cystectomy can cause significant damage to the ovaries in women who already have baseline, okay, compromised ovarian reserve, because endometriosis in itself can decrease the ovarian reserve and further decrease that ovarian reserve of doing the surgery. Okay, so this is an important thing that has to be discussed with patients who are where you are considering doing surgery on, and for those who are older and with already baseline diminished ovarian reserve. Okay, so remember this, up to 8 in 10 women Okay, 80% will have pain after 2 years of surgery. So you want to maximize the use of medical treatment to avoid repeated surgical procedures. So after a patient undergoes surgery for endometriosis, if not desirous of pregnancy, you should put them back again on hormones, okay? Can it be the form of oral contraceptive pills, can also use the progestins, can even use the levonorgestrel intrauterine system if a patient's looking at long-term control and or hormonal treatment. Now, long-term treatment of endometriosis. So long-term medical therapy is given to treat symptoms or prevent recurrence. And again, it's sad, but it is true, recurrence is frequent even after a very successful surgery. So that ends our lecture. So if you have any questions, Dr. Caringal and I will be here to try to answer them. And thank you again for being with us this afternoon and celebrating Endometriosis Awareness Month with us.
Thank you, Majoy, for that very simple lecture. I see 94 participants in our Zoom meeting now. Are there any questions in the chat box that anyone would want to ask? So let's start, Majoy, by putting on a predicate that endometriosis is chronic, it's progressive, it's recurrent, and can be systemic. So most of the questions here in the Google prior to our Zoom are asking mostly about adolescent endometriosis, maybe from 13 to 18 years old. And then some of the questions are pertaining to reproductive age endometriosis, the symptomatic type. The non-desirous of they're not desirous of pregnancy. They just want to control the dysmenorrhea, which affects their quality of life. So it's teen endometriosis and reproductive age group endometriosis dealing with symptomatology, meaning dysmenorrhea.
Okay. Sige, ma'am, what's the question?
So the question is how can they prevent the dysmenorrhea in this reproductive age group women not desirous of pregnancy?
Okay, so prevention of endometriosis or the symptom of the patient already has dysmenorrhea and we think it's endometriosis.
Correct.
Because per se, we cannot prevent the occurrence of endometriosis. Okay, women will have that genetic or immunologic disposition. So it's not a truly preventable disease. But if you have, you may do some things to help the possibility of it occurring if you know you have that genetic susceptibility, okay? So you can have a healthy lifestyle will definitely be good, okay? So an anti-inflammatory diet, being active, those happy hormones, okay, will definitely help prevent, but not, I think, completely prevent it from happening. Now, if you do have symptoms, okay, we can treat the symptoms. So it's not truly preventive anymore. But I can say that treating them can prevent the endometriosis from becoming worse or from becoming even, there's this thing that they call central sensitization, which is an important concept in endometriosis. Because when a patient is used to have feeling pain, eventually, it affects or completely parang nagmo-model na yung nerves dun sa central nervous system so that even just a slight insult, konting pitik lang, it magnifies. It's expressed or the patient perceives it as a severe form of pain. And if there's already chronic sensitization in patients with endometriosis, it becomes even more difficult to treat. Okay, so that's why early diagnosis. So if patients have, dysmenorrhea, you think it's endometriosis, then we start treating them. Okay, we consider hormonal treatment for these patients, maybe the form of progestins or even in the form of combined oral contraceptive pills to help them, to relieve them of these symptoms. Now, like we mentioned earlier, classically, we would, the way to diagnose endometriosis is to do laparoscopy. So it's only when you get a biopsy and see that endometrial gland stroma, no? And then you say, this patient has endometriosis. But now we don't have to wait for that. So if there's a clinical suspicion of endometriosis, so proper history taking, do a good pelvic examination, consider doing an ultrasound. But even if ultrasound findings are negative, you can still diagnose these patients as clinically having endometriosis. We start treatment. So parang empiric yung treatment. And then if there is improvement in symptoms, we continue until the point when patient wants to get pregnant. We discontinue hormonal therapy and then start trying to get them pregnant.
Yeah. So it's mainly therapeutic trial to improve quality of life. And a negative ultrasound doesn't mean you don't have it, because we have the peritoneal type of endometriosis as well. So there's a question here from an intern. Can I lose weight to cure endometriosis?
Okay, weight loss in itself, I don't think will cure endometriosis, but having a proper diet, okay, healthy lifestyle will be the one that can help with managing the symptoms, okay? So it is important, like I mentioned earlier, you can find an anti-inflammatory diet, you can look it up, okay, it will help. So avoiding food that has a lot of estrogen, such as red meat, no soy, might actually help with control of disease, okay? Non-fat food, not fried food, no, hindi yan okay for endometriosis kasi very inflammatory siya. Okay? So we believe that diet modification and encouraging the patient to be active may actually help to some extent control the symptoms of endometriosis. Now, one thing that you have to understand about endometriosis is we can't control all cases of endometriosis related pain with just surgery or with just medicine. Sobrang multifactorial yan. And for patients who have really severe forms of pain, we actually even offer pelvic physiotherapy. Some will undergo acupuncture. We even refer some patients to, especially the young patients, to psychiatrists, okay? Because the pain may be manifestation of an underlying psychiatric or psychosocial issue, and the therapy with the psychiatrist may actually help with the pain control as well.
So another question, is there no permanent solution for endometriosis apart from taking the hormone pill?
Okay. We wish we had that magic pill. We wish we really do. So, but since endometriosis is super multifactorial, unfortunately, right now there is no one magic pill that can help, or even that hormone pill is not even guaranteed to help control the symptoms, no? But unfortunately, there is no one magic cure. It will all be a combination of both medical, or so medication, and lifestyle changes, I think, that can help address the symptoms. There are those who just respond easily, with you just take the pill or take the progestin, okay na okay sila. But there are those, we have to, it's a trial. Yes, ma'am, di ba? We have these patients. They're not too many, but there are those talagang yung response nila, meron pang mga progestin resistant, endometriosis, and all of this. Now, in the there are lots of studies for new drugs working in the micromolecular level, and we hope that one day we do get that drug that can actually address endometriosis very well. And another magic drug will be one that can address endometriosis and infertility at the pain of endometriosis and infertility at the same time. Because, di ba, Ma'am Emma, it becomes challenging when the patient comes with both these symptoms, and you will have to prioritize one over the other, especially if a patient has limited funds. Because for infertility, moderate to severe endometriosis, we consider doing IVF, or even for patients who do not have who are not married or not in a relationship or walang sperm, no? We do even consider doing fertility preservation for these patients, because it is a known subset or population of patients where we know even for younger patients, if they are afflicted with this disease, that their ovarian reserve may be less or compromised.
So another question is there a cutoff size for an endometrioma to be removed? Or can medical treatment shrink the size of the endometrioma?
Okay, so thank you so much for these questions. So can medical treatment shrink the size of endometrioma? Yes. Okay. And we do see this in our patients, and that's why we checked after 3 to 6 months of medical treatment if the size of the endometrioma will decrease. Okay, so very good experience, and I'm sure the OBGYNs here have seen this. Sometimes for patients who we do give like the progestins, the Unigest or GnRH agonists, and the size does not decrease, then we worry a bit more because why isn't the size why isn't it becoming smaller? Is this actually a malignancy? So then we start considering doing surgery for these patients. But yes, particularly for the Unigest, it has been compared with combined oral contraceptive pills. The size decrease is much more evident in those who took the progestin-only pill, the progestogens or progestin. Okay. Is there a cutoff size for an endometrioma to be removed? Okay, it will depend on the author. Okay, in 2013 ESHRE guidelines, they actually published a 3 to 4 centimeter cutoff size because they said that you'll have to rule out the possibility of malignancy in these patients. But then they realized, okay, years after that, that with surgery, the ovarian reserve or the AMH of these patients will actually become less kasi na-affect. So if you have an apple, the ovary, and then there's a cyst there, when you do surgery, you take a bite of that apple. So you end up with just a smaller slice of the apple. And that becomes the ovarian reserve of these patients. But another thing to remember, baseline, the apple of patients with endometriotic cysts particularly is already smaller than the usual apple of a woman who does not have endometriosis. So doing surgery in these patients will further compromise an already compromised ovarian reserve. Okay, so now there are no guidelines will claim to have a cutoff size for recommendation to remove an endometrioma. I have done medical management in patients with endometriotic cysts as large as about 7 or 8 centimeters. Now, why will I not do surgery in these patients? Because unfortunately, some of these patients had already undergone surgery and already had the previous oophorectomy. So if you have that one remaining who has not delivered the baby, then of course, very aggressive ako to just try to shrink that or even although it is not usual, even to aspirate it just to decrease the size of that endometriotic cyst, no? And probably I will not, I will truly not try to do surgery on these patients until, unless I am pushed to that point or until the patient already has embryos stored and then I'm ready to do embryo transfer for her.
So another question is for how long can we offer medical treatment, specifically the Unigest?
Okay, so there's already a couple of long-term studies with the use of the Unigest. If I'm not mistaken, there is one, I'm sure there's one that's 5 years and 5 months. And then I think one that is almost 7 years. And I'm sure in the next couple of years, the same subset of patients, we will find out, we will get data 10 years and 15 years down the line. So right now, it is considered safe to use long-term.
The therapeutic index of the Unigest is pretty long. So can the Unigest be given to teens with endometriosis?
That is a fantastic question. Okay, they actually made this study. So it's the Visado study, but the population will include women, I think, until the age of 18, I think 19. That's why I tried to remember it. So they found that it was very, very effective for control of pain. Super effective. As a matter of fact, in 1 month, 3 months, significant drop in pain symptoms. However, they found that after, I think, 1 or 2 years of use, that there was a decrease in bone mineral density. although they think that it was not very big. So what is their advice about it? Okay, so you still have to consider the benefit of giving this for relief of symptoms. Okay, especially adolescents. Kawawa naman yung mga yan. Kailangan ng quality of life, right? And then, but you have to discuss with the parents that, you know, we have to monitor the bone mineral density of these patients because this is a known and established effect based on this large VISADO study. So I have given it to our patients. So one thing about progestins, by the way, and the use of hormone therapy and combined oral contraceptive pills, in my practice, I've already included in the review of the past medical history whether or not these patients have depression, history of depression or anxiety disorder. And you'll be surprised. After going to, do you have any known or significant medical problems? They will not share that until I ask them directly whether or not they have. Because giving them hormones may affect the mood, okay? So I have a couple of patients, when I give them progestins, will actually say that they feel really low. Parang very down sila. And of course, then you will say that, okay, this is not for you, then we have to find something else that will work for you.
So it says here, what is the best treatment for adolescent with endometriosis?
I would consider giving the Gynecology, and I think it's one of the best treatments available in the market today.
Can PCOS coexist with endometriosis? Another question.
Definitely. Okay, we have these patients who have it all. Okay, PCOS, endometriosis, okay, adenomyosis, myoma, all in one patient. So kung talagang nga sila kaswerte. But for these patients, maybe those with PCOS, I might consider giving them something, maybe not progestins. I would probably consider giving them combined oral contraceptive pills instead. Ma'am, I mean, that's what I would do.
Agree. So a question, is endometriosis a reaction of the body to inflammation? What are endocrine disruptors and can it cause endometriosis?
Oh, definitely. So there are lots of studies about endocrine disruptors and endometriosis. I believe from maybe historically, if you have mga relatives who were OBGYNs who are much, much older, they will say that endometriosis wasn't as common before. Okay,
Yes.
so the endometriosis, the disruptors, definitely in the environment, highly inflammatory. The food, diet pa lang, no? Very, very different. High fat, no? Very, yung oil. So lots of inflammation, causes a lot of inflammation in the body. So endocrine disruptors definitely have a role in endometriosis and the inflammation that is coexistent with endometriosis.
So another question is, how often do you request bone densitometry on patients on Gynecology?
I don't, I don't. There is no recommendation to do regular or any even periodic bone screening for patients who are taking the Gynecology. Okay, that recommendation is for the reproductive age women. Okay, so that's why we said the safety signals in patients. Yung mga long-term studies po actually say it's quite safe and there's no recommendation to monitor that. But that bone issue is actually very important in the adolescent age group where there is the pooling and yung pag-store ng lots of you're really optimizing the bone. It's during that age, okay? So that's when it is significant. They did not give recommendations on actually whether or not you should do bone screening at the end of 1 or 2 years, but they just said to advise the parents that that is a side effect if the Gynecology is given to the adolescent age group.
Maybe an alternate to Gynecology can be a Mirena. In other countries, they do that as first-line treatment for teen endometriosis with dysmenorrhea. You agree?
I agree. I'm a big fan of Mirena. The issue sometimes, especially in a country like ours, no, very conservative, okay? We know that a lot of these agents are contraceptive. Imagine having to insert an IUD to a supposedly virgin patient, okay? So the parents might actually have issues about that. Even the use of combined oral contraceptive pills in the adolescent may be an issue for some patients, the parents of adolescent patients.
So when to advise patients to stop medication for patients who want to conceive?
Oh, So it's going to be a plan. I tell them you can't just stop immediately without having a plan on how you're going to get pregnant. Because like I said, if you stop it, the pain can come back in 1 month. I've seen some patients doing so well, and then they stop, then 1 month later, the pain is back. Usually it will be about 3 months. So if they want to stop, and then because they want to get pregnant, I tell them, okay, before you stop, I think you should see me so we will have a plan. Okay, ano bang plano natin? So again, for moderate to severe endometriosis, it would be to consider doing IVF. Are you ready to do that? Okay, let's do your AMH before you actually stop. Para alam natin kung ano. Have the semen analysis of the husband ready. Ano ba yung status? So you'll have a plan before you stop taking the hormones. And that's how I do it. Or check the tubes before the patient actually stops. Diba? So you do the full fertility workup just to see kung anong level of fertility treatment this patient has to undergo.
So, and then an interesting question, distinguishing period pain, when does it become a cause for concern? Because pain can be subjective in any woman. So how do we delineate from pain that has to be investigated or pain that the parent says, mana-mana lang yan, or that's how I do it, it'll go away?
You know, if it bothers you, then I think it warrants investigation. Okay, it should not affect the quality of life. So to the point na we actually ask patients to rate their pain, and then they start saying it's 5, 6, then, or doc, I have to take pain meds, or I have to take time off from work. For adolescents, they have to take time off from school, or they cannot go out with their friends because masakit. Then, of course, that needs to be investigated. Okay, so if it bothers you enough, then I think it has to be investigated. If a patient can say, tolerable, doc, okay lang, alam mo yun, then maybe it's just really primary dysmenorrhea, okay? But if it is significant enough to cause discomfort, enough for you to miss activities or consider altering your whatever it is that you have to do or your lifestyle, then I think it warrants investigation.
Yeah, or if there's a trend in the pain, like maybe doing a menstrual diary, characterizing the pain. If it's there, bothersome, progressive, more than 6 months, then we investigate. So last question, Majoy, not entirely related to endometriosis, but I have irregular menses and have a hard time keeping up with birth control, which I was prescribed to regulate my menstruation. Due to the side effect it gives me mentally speaking, are there other ways to help regulate this?
To regulate the menses, okay? So you will want to consider long-acting agents, okay? I would consider that. So the issue here is irregular menses, okay? So you do not want the lining of the endometrium to be, too thick, to become very thick, and for that to predispose to having endometrial hyperplasia or endometrial cancer. So you'll need to find progestin, okay, delivery of progestin to the body. So a solution would be to consider longer acting methods or depot of progesterone. So I would consider even the injectable, okay? But it is all, just remember that these agents are also contraceptive. Even the implant might be an option, or even the levonorgestrel intrauterine system. So the depot is 3 months, good for 3 months. The implant is good for 3 years. And the levonorgestrel intrauterine system is good for 5 years. Okay. I'm not sure what's due to the side effects it gives me, mentally speaking. I'm just not sure. It will not regulate your menses because progestins are notorious for causing abnormal bleeding. But what you want to address are the complications of you not having regular menses. Okay, so that's what I think. I'm just not sure, ma'am, if I fully understood the question.
Parang she wants a different form, the one you said, the long-acting reversible contraception, but this will not regulate your cycle. Okay.
Right. It won't regulate your cycle, but it will prevent the complication of having anovulatory bleeding.
Yeah. Or maybe choose a different form of oral contraception that doesn't interfere with your emotion. She says mentally speaking. So I don't know if she feels sad or depressed when she's taking the pill, or she might have missed a
I thought
she has AUB.
I thought it was because nami-miss niya yung pills. Or I'm not sure if they're kung mentally it causes yung mga depressive symptoms or anxiety. Now here's the thing, okay? I found that if you say, Doc, I don't feel so well when I'm taking this certain pill, I ask them, what are you taking? And then it's not all pills will have the same effect on one patient. And even the same for some patients, even the same formulation, ibang brand, iba din yung effect sa kanila. So I tell the patients it's a trial and error thing. If you're willing to keep up to do this with me, okay, we will find something that will work for you, something na hiyang sa kanya. So if the problem is a certain brand causes anxiety or poor mood or mental issues for you, you may actually want to consider a different brand. That is something that you may consider, or even less systemic hormone like the levonorgestrel intrauterine system, although it can still, you will have a small percentage of systemic hormone that is dissipated in the body. It's not as much as if it is the hormone is taken orally.
Maybe a different kind of progestin and a lower dose of ethinyl estradiol for her.
I would consider. Yes, ma'am.
So any other questions in the chat box? Okay, so I've read all the questions before and in the chat box. In the interest of time, there are no questions. I'd like to end the question and answer forum for our session today. And
Thank you, Dr. Caringal and Dr. Joy. Even if this is a lay forum, I really learned a lot also, no? And please stay, because I would like to ask Dr. G. Lazaro to come here to the virtual floor for the awarding of Certificate of Appreciation for our speaker and moderator, Dr. G. Dizon.
Yeah, hi, Tina. I
Hello.
would like to thank Dr. Joy and Dr. Emma for a very wonderful presentation. So I would like to, can you flash the certificates? First, I would like to give this Certificate of Appreciation to Dr. Emma Caringal in recognition for sharing her valuable contribution as moderator in the Endometriosis Don't Suffer in Silence, Let's Talk About It period, given this 29th day of March 2023 at the Makati Medical Center. Signed by Dr. Mercedes Viduya, our department chairman, Dr. Cristina Miravales, the head of OPD outpatient and Ob Gyne outpatient and Layfora, and yours truly. Thank you, Dr. Caringal. And next we have, we want to give the Certificate of Appreciation to Dr. Margaret Joyce Cristi Limson in recognition for sharing her valuable contribution as speaker in the Endometriosis Don't Suffer in Silence, Let's Talk About It period, given this 29th day of March 2023 at the Makati Medical Center. Again, signed by Dr. Mercedes Viduya, our chairman, and Dr. Cristina Miravales, the head of Ob Gyne outpatient and Layfora conferences coordinator, and yours truly. Thank you to Dr. Limson and Dr. Caringal.
Thank you, Dr. Lazaro Dizon. By the way, Dr. Dizon is our residency training officer. So I'm going to call on our chief resident for the closing remarks, but afterwards, the video of the DR packages will be shown, and we can also have our group photo. Or you want the group photo first, after the closing remarks? After the closing remarks, okay. May we call on Dr. Cristiana Kalupitan, the chief resident, to give us the closing remarks, and afterwards we're going to have the photo.
Hi, good
Dr.
evening.
Shana.
Okay. Hi, good evening, everyone. Thank you all for attending this lay forum on endometriosis. I hope that the information presented here has been informative and helpful. It's important that we continue to spread awareness about this condition so that more women can receive better treatment options. I would like to extend my sincere gratitude to our esteemed speakers, Dr. Caringal and Dr. Limson, for sharing their valuable insights on endometriosis. Your knowledge and expertise have helped shed light on this complex condition and have provided us with a deeper understanding of its impact on women's health. I would also like to thank all attendees for their attention and engagement throughout the forum. Lastly, I would like to thank our sponsor, Bayer. We appreciate your partnership in making this event possible. Again, thank you, everyone.
Thank you, Dr. Kalupitan. May we now ask everyone to turn on your camera. And I would like to acknowledge the help of the two residents, Dr. Jamie Young and Dr. Lorraine. They're the ones helping us for us. They're working at the back, no? They're my IT people. Okay, Lorraine, can you take the photo?
Yes, but again, may we ask everyone to turn on their cameras for the photo op.
You can remove the yan. Mag 1, 2, 3 ka. First panel.
Yes, for the first panel po. The next panel, 1, 2, 3. Last panel, 1, 2, 3. Okay. Thank you po, doctors, and to our other patients.
Thank you very much, everyone. Now we're going to show the video of the DR packages, and then afterwards we can leave.
I am Dr. Darlene Hu, a senior resident from the Department of Obstetrics and Gynecology in the Makati Medical Center. We have a very competent staff composed of 11 residents, 57 nurses, 10 orderlies and nursing aides, and 3 technicians who can cater to your needs.
I am Dr. Kalupitan and I'm the Chief Resident of Department of Obstetrics and Gynecology, Makati Medical Center. We have several packages that you may avail in our delivery room. We have semi-private and small private packages, which includes the delivery room charges, basic medicines and supplies, laboratory, room and boarding, care of the baby, and professional fees of the obstetrician, anesthesiologist, and pediatrician.
I am Dr. Maria Micaela Vito Comendador, and I am a senior resident in the Department of Obstetrics and Gynecology in Makati Medical Center. For Makati Medical Center, what sets us apart is the competent staff, the complete and updated facilities, and of course, the atmosphere of compassion, which helps our patient have a more comfortable stay.
Thank you for listening. Thank you, everyone. Have a good night. Thank you. Thank you,
Salamat
Dr.
po. Thank you.
Thank you, doctors.
Thank you, everyone.